Bless the Lord, oh my soul, oh my soul, I worship His holy name. Sing like never before, oh my soul, I worship Your holy name. The sun comes up, it's a new day dawning. It's time to sing His song again. Whatever may pass and whatever lies before me, let me be singing till the evening comes. Bless the Lord, oh my soul, oh my soul, I worship His holy name. Sing like never before, oh my soul, I worship Your holy.
Good morning. There is a slight delay in the faculty's arrival. Sir has just started from his hotel, and there's some traffic problem also in and around where he's staying. So just I got a call that they are being a bit delayed. So thank you all for your patience. We are expecting to start at 8:30. Thank you.
Good morning, 2019 batch students are here. When are you going to give your exams? Okay. When did you give your biochemistry exam? 2021. 2020, okay. I gave my biochemistry exam in 1978. Okay, so my memory of inborn errors of metabolic is very
Good morning, everyone, and good morning, Professor Das. Uh, it's really a privilege to be here today in today's Quest program. Now, usually we have this program on Thursday mornings, and that might be probably, since it's a Monday morning, we have a scarce attendance today. So, and also there is an undergraduate exam going on, I understand, from Professor Jijo. And Professor Das, for the sake of audience, had come for our biochemistry conference, ACBACon in Trivandrum last year. And he was very keen on visiting our institute and especially interacting with the pediatrics department over here. So he was asking whether it's possible to come over. So we had arranged a quick trip to our hospital. Now he is actually head of the Pediatric Metabolic Medicine Department, Metabolic Medicine Department of the Department of Pediatrics, Hannover Medical School in Germany. And he has done his undergraduate studies of medicine at Göttingen University in Germany. And he was a scholar of the Max Planck Society in Göttingen, where we worked in respiratory physiology, and followed by a postdoctoral fellowship in the Department of Biochemistry, Oxford, UK, and where his focus of research was the regulation of cardiac energy metabolism. And Professor Das trained in pediatrics at Hannover Medical School and University Clinics in Hamburg-Eppendorf. Is that right? Yeah. I'm sorry for my German pronunciation. So, yeah. His special interest is in inborn metabolic disorders and neuropediatrics, with a research focus on energy metabolism, amino acid metabolism, and lysosomal storage disorders. He has also obtained experience in newborn screening at the Screening Laboratory Hannover, and he is also an adjunct visiting professor at the Department of Biochemistry at Kasturba Medical College, Manipal University. And Professor Das is a member of the Scientific Advisory Board of the German Society for Muscle Diseases, the Center for Systems Neurosciences in Hannover, and the Center for Rare Diseases, as well as the Ethical Review Board at Hannover Medical School. So that's just a brief introduction. He is heading the newborn screening laboratory in Hannover, if I understand correctly. And
actually, the newborn screening laboratory is a private institute.
Okay.
But we have a very good cooperation with them.
Okay. And he also travels widely, and recently he was presenting at the SSIEM conference, the Society of New Inborn Errors of Metabolism in Jerusalem, before coming over to India. And he has been very kind enough to accept our invitation to come over to Believers also. So thank you, Professor Das, and over to you.
Okay.
And Professor Jijo, would you like to? Okay, he would summarize at the end. Okay, please.
Does this work? Can you put the microphone on? Yes, thank you very much for this kind introduction. So I will talk today about the basics of inborn errors of metabolism regarding diagnosis and treatment. So almost all of the inborn errors of metabolism are orphan diseases. This means that they are rare. We have nowadays more than 1,000 different metabolic disorders, which makes it quite complicated to be familiar with all of the diseases in this field. And every year new disorders are discovered and described. 80% of the orphan diseases have a genetic cause, and mostly they are chronic disorders. And 75% of orphan diseases affect children, so we as pediatricians have to care for them and also be aware of the possible symptoms. So what is metabolism? So metabolism means that substrate is metabolized, catalyzed by an enzyme to a product, or alternatively, transporters facilitate transport of a substrate from one cell compartment across cellular membrane to another cell compartment. This is Archibald Garrett, who more than 100 years ago described the first metabolic disorder. This was alkaptonuria, disorder in tyrosine degradation. And we have inborn errors of metabolism, where we either have an enzyme defect leading to the accumulation of the respective substrate and low concentrations of the respective product. And these can lead to the clinical symptoms and can also be used for diagnosing inborn errors of metabolism at an early stage. On the other hand, we have transporter defects, which lead to the accumulation of substrates in one cell compartment, and the substrate is low in another cell compartment. The transporter defects are mostly the so-called storage diseases, because the substrate is stored in one cell compartment, and yes, as you can imagine, it will take some time until enough substrate is accumulated in one cell compartment, and this is why these are chronic diseases which take time to develop symptoms. On the other hand, we have the enzyme defects, and these can lead to very rapid intoxication of the child or the patient, triggered especially by catabolism. And on the other hand, we have disorders of energy metabolism, where cellular energy depletion manifests as multisystemic disorders, so-called mitochondriopathies or respiratory chain defects. For children with inborn errors of metabolism, the first days of life are critical. As you know, as a pediatrician, every child loses weight in the first days of life, and this is due to the fact that the child has to learn how to suckle, and if he is breastfed, it also takes a few days until enough breast milk is produced to give enough calories to the child. For the children with enzyme defects, this is critical and can lead to self-intoxication, auto-intoxication of the child. So the trigger for metabolic crisis is catabolism. This can be a postnatal feature, but can also be a feature in later life during febrile infections, with a peak at 6 to 12 months of age. In catabolism, the caloric need is higher than the caloric supply. Hence, the body has to rely on the endogenous reserves like fat, carbohydrates, glycogen, and also amino acid stores, for example, in the muscle. From these endogenous reserves, amino acids, fatty acids, and carbohydrates liberated in an uncontrolled fashion, which is not a problem for those children with a healthy metabolism, but it can be a severe problem for children with an enzyme defect. So one of the substances cannot be completely metabolized. Toxic compounds then accumulate proximal to the defective enzymatic reaction, and then symptoms develop typically at the age of 2 to 5 days postnatally. While the child is still in the womb, the toxic metabolites diffuse into the mother's circulation, and the mother will metabolize these toxic compounds, but once the child gets out of the womb, it has to rely on its own metabolism, and if it does not work, then there's toxic metabolites accumulating. We have in Germany the newborn screening program as a preventive measure, which is done nationwide. I'm aware that in India only regional initiatives are there, supported by government sources mostly. So this is not a nationwide program at this time, but it may develop. So in Germany, the newborn screening is done on the second day of life. Blood is collected on these filter cards, and the blood is punched out with this appliance and then analyzed in this appliance, which is the tandem mass spectrometer. So in Germany, we nowadays use the tandem mass spectrometry as the highest throughput method to do newborn screening. This is Professor Guthrie, who in 1961 developed the first newborn screening test in the US. This was for phenylketonuria, PKU, an amino acid disorder where phenylalanine cannot be metabolized. And this was a bacterial inhibition test. So you can see here the bacteria, and the bacteria were given a medium which was devoid of phenylalanine, and then so they couldn't grow in this medium, and then the blood of the children was added, and if there was high amount of phenylalanine in the blood, then the bacteria started growing, and this was taken as an indication that phenylalanine levels were elevated in this child. But as you can imagine, this test was not very reliable, not very sensitive and specific. And nowadays we have biochemical methods, but this card is still called the Guthrie card after Professor Guthrie. So this is a tandem mass spectrometer. On the left side, you can see how the blood is punched out of the filter cards, and then it's analyzed. This is done 6 days a week. On Sunday, there's no mailing in Germany, so no samples will arrive. But on the other days, this program is active. So what does it mean? So we have punched out amino acid-free carnitine and acylcarnitines from the blood. Butanol is added to give butyl esters. They are injected into an ionic source. So the ions are separated by a first mass spectrometer, and then they collide with inert gases, and split products are produced, and these are separated in a second mass spectrometer, and you can get a panel of different peaks, different substances within 1 minute, so it's a high throughput method. And here you can see on the top the panel of a normal child, and here a child with PKU. You can see here the phenylalanine level, which is elevated, is not present in the healthy children. And you can analyze several hundred different compounds within 1 minute. So it's a really high throughput method. So you shouldn't include all the diseases which are known in a screening program. You have to be careful, and many years ago, criteria have been defined by Wilson and Youngner, and the most important, most practical criteria are the following. Do we know the natural cause of the disease? So we have to know if it's a severe disease, and what's the natural cause of the disease, if we can modify the natural cause of the disease by a newborn screening program. There should be a good therapy, otherwise it doesn't make sense to screen for a disorder. And there has to be a good screening test. The sensitivity and specificity should be high. We shouldn't have any false negatives, and also the number of false positives should be limited. So the last point is the test acceptable to the public, which means that the burden for the child and the family shouldn't be too high. This blood can be collected by a heel prick, and so this is not a very high burden to the child. And also the cost should be minimal and shouldn't be too high for the health system. So I now come to the timing of blood sampling for the newborn screening. It's at 36 hours of life, and in most cases we can then discover affected children pre-symptomatically. Metabolic crisis, as I mentioned, is triggered by postnatal catabolism, and it can occur even before screening results are available, but still knowing the results is an asset, because then you can put the child at specific therapy and limit the decompensation. These are the target diseases of a newborn program in Germany, still under revision, so more diseases will probably be added in the next few years. So we have biotinidase deficiency, vitamin H deficiency, which you can simply treat with vitamin H. Otherwise, if you don't treat it, children develop severe mental retardation, inner ear deafness, and this you can prevent by giving the children vitamin H tablets. Then we have classical galactosemia, where galactose cannot be metabolized to in the children, and this can lead to liver failure and also mental retardation and eye problems. Then we have the amino acid disorders like PKU, phenylketonuria, that's the most common one in Germany. MSUD, maple syrup urine disease, so this is a disorder in branch chain amino acid degradation, and the children smell like maple syrup. And then we have hepatorenal tyrosinemia, or HT1. Then we have some fatty acid oxidation defects. The MCAT deficiency, medium chain acyl-CoA dehydrogenase, is the most common one. And carnitine cycle defects we have, you know what carnitine is used for from your biochemical lessons. So carnitine is needed to transport long-chain fatty acids into the mitochondria for beta oxidation. And if there's a carnitine deficiency, this cannot happen. So there's a defect or lack of energy, especially in muscle and cardiac muscle. And also ketone bodies cannot be formed in the liver. Then we have organic acidurias, glutaric aciduria, and isovaleric acidemia. Then we have endocrinological disorders like hypothyroidism and adrenogenital syndrome, severe combined immunodeficiency, and a new addition is spinal muscular atrophy. This is a genetic test, sickle cell anemia, and cystic fibrosis. Every child who has been tested positively for an inborn error of metabolism gets an emergency pass with recommendations for the doctor at home, what to do first and whom to contact for further advice. All other metabolic disorders rely on clinical suspicion or suspicious history. And then if metabolic disorder is suspected, selective metabolic screening is ordered, and the suspicion can be proved or can be stated that it's not correct. For example, in lysosomal storage diseases, you have these typical coarse facies, typical hair, and here on this right panel and the lower panel, you can see skin abnormalities here. And this is an adult patient. He had skin depositions. This was first thought to be due to hyperlipidemia, but he had normal cholesterol levels. And it turned out that he has a lysosomal storage disorder. So when should I consider an inborn error of metabolism? There are typical clinical symptoms. Some children develop septicemia with negative infection parameters, so then you should always suspect also a metabolic disorder. Encephalopathy of unknown cause with symptoms like coma and epilepsy should lead to suspicion of an inborn error of metabolism. Acute liver failure, hepatopathy of unknown cause, cardiomyopathy of unknown cause, and especially multisystemic diseases. As I mentioned, toxic compounds accumulate in the body and they can reach all the organs of the body, and so also affect many organs at the same time. If in history there's aversion against certain food, for example, if the children do not want to take fruits or fruit juices, this may be a suspicion for hereditary fructose intolerance. And also if the child has a peculiar body odor, I also already mentioned maple syrup urine disease, then this can be a first sign of an inborn error of metabolism. Hyperventilation can also be a first sign. For example, in hyperammonemia, I will have a case report later on. Then there are certain laboratory parameters which should make you think of an inborn error of metabolism. If there's hypoglycemia, which cannot be explained by other disorders, metabolic acidosis with increased anion gap. So anion gap is sodium minus chloride minus bicarbonate. Then metabolic alkalosis, and not only increased urea levels are pathological, but also low urea levels could be abnormal. Most physicians look for elevated urea levels as a sign of kidney dysfunction, but you should also be aware that low urea levels may be pathological and may point to an inborn error of metabolism. Then we have, of course, hyperammonemia and the urea cycle defects, and lactic acidosis, which cannot be explained by hypoxia or ischemia, can be a sign of an inborn error of metabolism. So what are the therapeutic options in inborn errors of metabolism? There's substrate reduction. If the toxic compounds comes from the nutrition, then we have the option of a diet, and we have to be careful that the patient does not become catabolic. Then if there's endogenous production of the toxic compounds, we have the option of pharmacological therapy in some of the disorders, like tyrosinemia. In tyrosinemia, we can give the children nitisinone, which has originally been developed as a herbicide. And then during side effect testing or toxicity testing, it was discovered that it also had an effect on tyrosine metabolism, and then patients were treated with this herbicide, and the effect was very good. Formerly, the children died in the first months of life, and nowadays they have a normal life expectancy. Then cofactors and vitamins can be given, like biotin, which I mentioned in biotin deficiency. Biotin is vitamin H. For some disorders, enzyme replacement therapy has been developed for the lysosomal storage disorders. This is quite a costly therapy. Enzyme augmentation with chaperones, which stabilize a defective enzyme, which stabilize protein folding and thus increase residual enzymatic activity, and also the half-life of the protein can be applied. Then there's enzyme substitution, where you give a different enzyme, not the enzyme which is deficient, but an enzyme which can degrade the toxic compounds and thus detoxify the patient. And of course we have transplantation via bone marrow transplantation, and also liver transplantation if needed. But you have to be aware that children after liver transplantation are not healthy. They still have some risks like infection, like malignancy, and they always have to take immunosuppressive drugs. So that's not easy, but if children are with inborn errors of metabolism quite unstable under dietary or pharmacological treatment, this is an option. So what should you do if you have an emergency in an inborn error of metabolism? So after initial diagnostics, drawing blood and taking urine, you should give infusion of glucose 10%, add fluid maintenance with electrolytes. If you give too much of glucose in respiratory chain defects, you may trigger lactic acidosis. So in those disorders, you have to be a bit careful. If required, if the glucose levels go up, then you can also add insulin. And after 1 to 2 days, you should start protein with a low amount of 0.25 to 0.5 grams per kilogram per day to avoid long-term anabolism. In some disorders, you may consider hemodialysis to get rid of the toxic compounds during decompensation. You should start oral therapy as soon as possible, depending on the disorder. For example, in fatty acid oxidation, fat-free preparations, formulas are available, and also protein-free formulas are available for urea cycle defects or tyrosinemia. You should consider that the child gets enough essential amino acids and enough calories. So now I come to a clinical vignette, clinical case report, history. Parents were of Kurdish origin, they were consanguineous. It was the 5th child of the parents. One child died from sudden infant death syndrome at the age of 2 days. A cause was not given for this death. There's no family history of inborn errors of metabolism. The pregnancy was uneventful, birth at term, 39 weeks of gestation, weight, length, and head circumference were normal. APGAR score was also normal, umbilical blood pH a little bit on the low side, but almost normal. The child was started breastfeeding. On the 3rd day of life, the child became apathic, had feeding difficulties, tachydyspnea, and there was a weight loss of more than 10%. The child was presented to the local hospital, was already dismissed from the hospital, and then presented at the local hospital at the accident and emergency unit. And due to the clinical symptoms with apathy, feeding difficulties, septicemia was suspected. The child was given antibiotics and didn't get better. The first blood analysis revealed that the infection parameters were normal. pH was normal. PCO2 showed hyperventilation. PCO2 was low. Lactate was slightly elevated at 3.1 millimoles per liter. Glucose was normal. Creatinine was normal, and the urea was 1 micromole per liter, so it was low. Can someone of you has a suspicion what this child might have? So urea is low. Which pathway leads to the production of urea? Pardon? Yes, urea cycle. The colleagues could have suspected urea cycle defect at this stage, but they didn't. Were not aware of this low urea level. They only looked for elevated urea levels as a sign for kidney dysfunction, and they still were sticking to the suspected diagnosis of septicemia. They did an X-ray of the thorax and cranial ultrasound. Everything was normal. The child developed apnea with severe drop of oxygen saturation. 12 hours after admission, there was the first tonic-clonic seizure, which was treated with phenobarbital. Meningitis was suspected. The lumbar tap was ordered and done, and the antibiotic therapy was also increased with cefotaxime, which also goes to the brain. But nevertheless, apnea continued, became worse. The child had to be intubated and ventilated, and didn't get better, didn't get worse under antibiotic therapy, and they contacted our service at Hannover Medical School, and with the clinical symptoms and laboratory values, low urea level and hyperventilation, we suspected urea cycle defect and asked them to do ammonia testing, and indeed ammonia was 2,700 micromoles per liter, severely elevated. Normal in neonates is up to 100 micromoles per liter. The child was then transferred to our hospital via our neonatology team. And during transport, was given arginine, benzoate, carnitine, and glucose to tackle the elevated ammonia levels. He still had epileptic seizures when he arrived in our institution. A Sheldon catheter was placed, which would enable hemodialysis. But in the end, we didn't need it. In parallel, we infused glucose, gave benzoate, arginine, and carnitine. And under this conservative therapy, ammonia levels dropped from 2,700 to 900 micromoles per liter. Conservative therapy was continued, so no hemodialysis was needed, and there was a further drop of ammonia levels. So next day we did amino acid analysis in our metabolic lab. Citrulline was severely elevated with 1,600 micromoles per liter, normal is 38. And glutamine as a long-term parameter for ammonia was also slightly elevated. And then we had the diagnosis did not reveal, luckily, any significant brain edema. There was slow clinical recovery under conservative therapy and oral feeding, including low amounts of protein. So what is citrullinemia? It's an autosomal recessive disorder of the urea cycle. Enzyme deficiency is adeninosuccinate synthase, which is not a target disease of our newborn screening program. So here you can see the urea cycle. So from amino acids, when they are degraded, we get high amounts of ammonia, NH3, which is not water soluble, and in the urea cycle, using different enzymatic steps, this is transformed to urea, which is water soluble and can be excreted with the urine. So then you can get rid of nitrogen atoms. And in citrullinemia, we have enzyme deficiency here at the where the red bar is. So this is the enzyme adeninosuccinate synthase, which is deficient, and hence citrulline accumulates. And this is also was also the case in our patient, where we found elevated citrulline levels. At the same time, all amino acids which are proximal, distal to this enzyme deficiency like arginine become semi-essential amino acids and you have to replace them. Mostly the enzyme activity is not zero of this deficient enzyme. There's some residual enzyme activity. And if you then add arginine, you can still get some activity of the urea cycle and can get some urea production. So regarding urea cycle defects in general, we have several forms. The most severe one is a neonatal form with metabolic decompensation in the first days of life, is often irreversible neurological damage. Children suffer from anorexia, vomiting, lethargy, coma, seizures, brain edema, hypothermia, and tachydyspnea, as in our child. And this is due to the fact that amino acids cannot be metabolized to urea, and ammonia accumulates and toxifies the body. For diagnostics, you should do ammonia levels, of course, and amino acids in blood. And here you find elevated citrulline levels, and you can confirm this diagnosis later on with molecular genetic testing. Now I come to therapeutic principles. You should restrict protein and hence restrict the production of ammonia. Anabolism is important to suppress endogenous ammonia production. And you can give benzoate and phenylbutyrate as scavengers of nitrogen. So phenylbutyrate is metabolized in the liver to phenylacetate, which reacts with glutamine, giving phenylacetylglutamine with 2 nitrogen atoms. These are the yellow dots, and this is water soluble and can be excreted with urine. On the other hand, benzoate reacts with glycine, giving hippurate, and this is also water soluble. This only contains 1 nitrogen atom and can be excreted via urine. Then, as I already mentioned, arginine becomes a semi-essential amino acid and has to be supplemented, as shown here. And if dietary and pharmacological options do not work, then you have the option of hemofiltration. But this is of course a big burden for the circulation of a small child. And you can also induce catabolism, as you do not only wash out ammonia, but also other energy-rich compounds. This is dialysis unit in a bigger child. So here you have the filter, and here you have the vessels cannulated. In smaller children, you cannulate the vessels in the neck. And for the outcome, the duration of hypommonemia and to a lesser extent the peak value of ammonemia correlates inversely with the cognitive outcomes, IQ, and directly with cortical atrophy. So it's important to react quickly and to treat these children and diagnose them quickly. So this is a family of 3 children from these are 3 children from one family carrying the same mutation. The first child, this is a cousin of the 2 other ones, and this child was diagnosed at the age of 10 days and treatment was started. She was severely handicapped, had severe brain damage from this metabolic decompensation. And this was her cousin. The families did not have contact with each other, so the second family was not informed that this disorder was running in the family. And he was diagnosed at the age of 5 days and treated. He also has some brain damage and has to go to a school for children with special needs, so there's some handicap. And his younger sister was diagnosed prenatally and treated immediately, so she is normal. So they all carry the same mutation, but had a different outcome due to different time points of diagnosis. For emergency interventions, you should give protein-free diet. You should give enough calories. Benzoate and phenylbutyrate should be added as scavengers. Arginine should be supplemented intravenously. If not successful, hemodialysis should be applied. So our center is a member of the European Reference Network for Inborn Errors of Metabolism, the so-called METAP-EARN reference network. In Europe, there are several networks in place at the European level, and we are also an accredited training center for Pediatric Metabolic Medicine, accredited by the Society for the Study of Inborn Errors of Metabolism, SSIM, at a European level. And well, if you like, you could also do an elective or come for metabolic specialization. You can contact me, so my email is also seen here, and also if there are some special questions or problems with children, you of course may contact me anytime. So thank you for your attention, and I'm looking forward to your questions and comments.
We'll pass it on to Elizabeth ma'am for a few comments.
Good morning, sir. It was a very interesting talk, very simply given. I just have one doubt. I have worked in the Middle East. There are a lot of consanguinity there, and that we have seen a lot of children with urea cycle defect. In fact, my own professors, she had 3 children, and they're all survived. Now, the basic thing is consanguinity. Now, here we don't have much of consanguinity, being a Christian population, or even among the other population, people do not marry like in olden days. There is more awareness that there are problems which can be passed on to the next generation. So isn't that one reason, or rather we should emphasize to the next generation with antenatal counseling and preconceptional counseling? Is it better than, is prevention better than cure?
The switch is on. Yes, thank you for this question. Of course, it's better to have prevention, and well, we also have in our outpatient clinics a lot of patients with migrant background. A lot of them originated from Turkey or from Arabian countries, and they have consanguinity. And of course, it's important to do counseling at an early stage, but well, if there's no index case in the family, it's also difficult to do prenatal diagnosis. But of course, you can avoid many of the autosomal recessive disorders if there's not consanguineous marriage. But on the other hand, we also have a number of German patients where there's no consanguinity, so also there's a risk, but of course it's much lower than in the consanguineous marriages, and this is something which should be avoided.
Hello.
Hello.
Yeah, good morning. Professor Das, one of the things which has been said against newborn screening, especially in India, has been that treatment is most times not feasible in general.
Yep.
So what has been your experience, not just UCD, in general, what has been your experience with the outcome of treatment in for metabolic disorders?
Well, it depends a bit on the disorder. So some disorders, if you treat them at an early stage, they have a very good outcome for
Like UCD,
like UCD or also PKU, phenylketonuria. So that's not as dramatic as UCD. So there's no acute crisis, but well, if you diagnose the children within the first months of life, it may be even too late. So we have some patients who are in their 50s nowadays, and they were born before the era of newborn screening for PKU, and they have severe developmental delay. They cannot care for themselves, and this can be avoided if you start treatment in the early weeks of life. And this is also not a complicated therapy, and for some disorders the treatment is not very costly, and so it may also work in countries where economical restrictions are in place. But on the other extreme, we have the lysosomal storage disorders, where you have enzyme replacement therapy, which is really expensive. There are some compassionate use programs, and the government in India also finances some, but it probably cannot be done nationwide.
we had a series of patients actually, about maybe 50 amino acidureas and 50 organic acid, but most of them were like diagnosed, as you said, quite late, not early enough, and probably that's the reason why most of them succumbed. And
Yeah.
and probably if newborn screening was available, probably at least some of them could have been saved.
Yes, so it's important to start treatment early, otherwise there will be, for example, brain damage, which is often irreversible.
Because we have so many facilities and we have so many doyens in this field, can we start in believers with the support of Dr. Das, Dr. Kannan, Dr. Jijo Joseph, and Dr. Sumida, neonatologist? Can we start an intensive newborn metabolic screening here with your support? What is your opinion?
Well, in principle, it should be possible. We also know from other regions in India, for example, in Delhi or in Mumbai, there are screening programs in operation. But well, this is not only the analysis, that's a real program. You have to inform the parents before childbirth. They have to give their consent to do the testing, and of course afterwards there have to be follow-up of the positive cases, and of course the clinic has to have enough resources and experience to care for the affected children. But in principle, well, that's of course would be feasible, but it's not only doing the analytic part of the newborn screening, but you also have a clinical part, and you also have to follow up the patients. So that's really complicated, but I would think it's feasible. But of course, you have to get some support, some financial support, get enough staff to do this work.
Thank you, sir.
I agree to that, because unless the treating physician is available, an interested clinician is available, diagnosing by itself is not complete. It's just the start of the story. So, do you like to say something?
But of course, you can get someone trained. This can start with 1 or 2 people, and if they get some experience, probably should go to some bigger centers and get some training. Then it would be feasible. But of course, that's a thing which takes a bit of time.
So currently at our hospital we are screening regularly for 7 diseases.
So that includes hypothyroidism, CH, biotinidase, galactosemia. So 7 of them we are screening. The rest of it, so the aminoacidopathies, etc., we are going in for selective screening if they have symptoms. But like ma'am was rightly pointing out, because consanguinity is less, we don't see too many of those symptomatic IEMs in the newborn period. What we do see is there are some patients who come in with the history of a previous sibling having been affected. They come with the mutation, and we end up doing amniocentesis and ensuring that this child is not affected and they proceed with the pregnancy. So I think that is where we are currently regarding newborn screening at our hospital.
Yeah. Well, but well, if you do prenatal diagnosis, of course, you should also consider early treatment. But of course, this is not always easy, because this will be a financial burden to the patients. But well, sometimes you can get compassionate use programs, and also in India there are some companies who produce also special formulas for the amino acid disorders or organic acidureas. So this may also be an option instead of terminating the pregnancy.
Yes, sir. Formulas are being, I think the last 6-7 years we've been able to get the formulas. However, the cost of the formula is quite high. For example, if our regular formula is priced at around 500 rupees, these products are priced at around 3,000, 4,000 rupees.
Yeah.
So it's that much of an amount every 3 days.
Yeah.
Bit of a financial burden also.
So in principle, there should be some support for the families, but of course this is difficult, and it's always difficult to get some money from the politicians.
Thank you, sir, for that enlightening talk. As rightly pointed out, the numbers are quite less in our center. But as we all know, like Anand sir is saying, it is being very diverse. The story is not the same from one end of the state to the other end of the state, and it's different from one state to the other state. In the sense, we have Calicut and Trivandrum having a higher number of lot of inborn errors of metabolism. Towards Malappuram area, we have a lot of inborn errors of metabolism coming up, owing to a lot of consanguineous marriages happening in those areas. So what we are telling you is only about maybe a district and a few districts around us, but the picture is different between different places. The thalassemia is a major issue when it comes to Maharashtra. Government has taken it up. So something new which had come up, cystic fibrosis is a major issue coming in Tamil Nadu, Bombay, Delhi, all the centers. So something new which had come up recently was there's a national policy for rare diseases which has come in 2 years back, wherein they have told they have summated illnesses into 3 groups. So the first group is disorders amenable to one-time curative therapy, which includes stem cell, organ transplantation, renal transplantation. Group 2 are diseases which require long-term treatment at lower cost of treatment, but a benefit has been documented and with enough literature, and there are special dietary formularies available, and also disorders that are amenable to other forms of therapy, including hormones and specific drugs. And group 3 includes the disease which is sufficient evidence for good long-term outcomes, which includes the LSDs and DNAs for cystic fibrosis. So the financial support are for up to 50 lakhs for patients in any category of the rare diseases by the government. This is one time in a life, single payment. And group 2, the state government will take responsibility, and the group 3, it has to be by crowdfunding. Government is planning for a website wherein they can be documented. As of now, there are only 10 centers of excellence across the country. The closest one for us is right now in Hyderabad and ICH Chennai and in Bangalore. So these are the centers which are set. So these are things which are happening right now. There is a rare disease organizations group which has come in, which is primarily parent fund. Parents are the ones who have been behind it, and there are support groups coming up. So it's still in a nascent stage, so things might change, and as this point, the priority is more towards immunization, than more vaccines are still coming in. And we are sure once we reach the next level, we will have newborn screening becoming across board. The one which Dr. Sumita talked about is what is happening in our institution, which is not a norm for across the state, wherein even at this point, thyroid is the only thing which is being screened across board in Kerala per se. So we are still a lot of way behind, but we would love to have you on board with us when we have difficult cases, wherein we would like to have your guidance regarding treatment on an emergency basis and also regarding a long-term prognostication, because your experience will definitely help us.
Yes, it's a pleasure for me to do it.
Thank you, sir.
But well, that's a good development. Also, also in Germany, there's a lot of pressure from the parents and the patient groups. Otherwise, the politicians, they are not aware of the importance of rare diseases. They think they are rare, so they're not that important. But of course, pressure from the patient groups is important.
So there are some states which kind of support more than other states depending upon the health system. Tamil Nadu does support more of cochlear implants, and now bone marrow transplantations are coming up in the state pattern. So it is still in the nascent stage. So even the one which I talked to you about 2021, this has not come in to the hands of the patients yet. This has just been passed, so it has not yet reached the patient level. So hopefully in time we will have a national screening program which will be given as much as an importance as national immunization program.
Yes.
I would like to invite Elizabeth ma'am for a small token from our side. I would also like, and Kannan sir to come in to hand over sir a small token from of appreciation from our side. I hope this is beneficial for the MBBS students who are here with us. Sir teaches in a university which has 400 medical students every year. So he is from a center of excellence. We are absolutely proud to have sir with us today, and we would like to thank Kannan sir in the biochemistry department for helping us bring sir over here, giving us an opportunity to interact with him. Rendu.
He represents academics and I am clinical. Thank you.
The meeting is adjourned for today. Thank you for attending.